Hi everyone, Assalamu alaikum. Once again, thank you for having me back here. It has been a wonderful session, I'm sure, with lots of insights into various aspects of retinoblastoma. Thank you, Dr. Ihab, for having me here once again, and also for giving me the responsibility to talk on this very, very important topic on advanced retinoblastoma. And why is this important? Like, coming from a region where I am from India and with experience in China, most of the cases, majority of the cases presents with either advanced intraocular disease or extraocular disease. And I'm sure the scenario is not much different in Egypt either, compared to the West, where a disease is diagnosed much earlier and most often the disease are less advanced than what we see. Once again, I have no financial disclosure or interest, and this is my team. I'm extremely grateful for their work in supporting, in salvaging the life of all these patients. And I have to express my gratitude to all these researchers, including my mentors, who have tremendously contributed to various aspects of retinoblastoma management and from whom we have learned a lot in managing even these difficult cases. I have put the headline as retinoblastoma in low and middle income countries. And why is that important? Because it is these countries which actually faces the challenge, even in 2024, with delayed diagnosis, with misdiagnosis, and finally landing with advanced disease. Now, before going on to the treatment strategies, it is important to know how we can prevent this situation. So, as a responsible clinician, it is so important to raise social awareness and with educational activities among physicians, among pediatricians, among public regarding this disease so that it can be diagnosed much earlier. Affordable care, accessible care, which can close the care gap where the patient may not abandon the treatment and get lost to follow-up, which is very common in our part of the world. Continued medical education among doctors, and referral of these patients to retinoblastoma treatment centers with the experts in order to avoid misdiagnosis and timely referral. These are the kind of presentation that we have in our practice, where this child had a small white spot seen by the physician earlier, asked to observe, and finally progressing to have this ophthalmic eye, a right eye, and advanced intraocular disease in the other eye. In fact, fortunately, I was able to salvage the left eye with very, very minimal vision. So we have found that the mean duration from symptom to diagnosis was 6 months in a series, and 19% of them had reached pediatricians. Advanced diseases like intracranial extension, it's very, very difficult, challenging situation to salvage the life, and extraocular extension of retinoblastoma is yet another challenge in our part of the world, where it presents 6% in our series, but it is as high as 30 to 60% in countries like Africa and South America. So in our series, more than 50% of the patient presented with advanced intraocular disease like group E eyes. So group D disease, yes, it's a challenge. It's very difficult to salvage the eye. When it comes to group E, is more about salvaging the life. With the available treatment strategies in retinoblastoma like systemic chemotherapy, intra-arterial chemotherapy, intraocular chemotherapy, plaque radiotherapy, we have been able to salvage even advanced intraocular disease to a certain extent, where in this case, bilateral retinoblastoma, left eye, ophthalmos, and this is the right eye with advanced disease, a large tumor with endophytic involvement with chunks of vitreous seeds sitting here. Well, I went ahead with systemic chemotherapy. This is after encouraging to see this situation after 3 chemotherapy, post-chemo 6, and intravitreal topotecan with the tumor, which is seen as a well-differentiated tumor post-treatment, settled down with reasonably good vision in this child. The patient, 6-year-old patient presenting with this intraocular retinoblastoma, where the entire vitreous is filled with tumor, involving also the ciliary body in the 6 o'clock hours here. So when the parents definitely wanted to try salvage the eye, went ahead with systemic chemotherapy, 6 cycles, periocular topotecan, until I could find a space to go inside to give intravitreal topotecan after partial regression of the vitreous component. Also plaque brachytherapy for the ciliary body tumor, finally the eye was salvaged with good vision, almost 6/6 vision in this eye. So my experience with intravitreal topotecan has been promising with 90% eye salvage. This was a learning case that I came across during my fellowship with Dr. Carol, and how she managed was a great lesson for me. This was a patient who was earlier misdiagnosed as uveitis and further progressed to form this lesion in the angle where biopsy was done, retinoblastoma was confirmed, but the posterior pole was absolutely normal. So it was a diffuse anterior segment retinoblastoma where the patient was treated with systemic chemotherapy after placement of plaque brachytherapy. There's an iodine plaque placed over the surface with complete resolution and regression of the tumor with eye salvage. So similar lines when such patients present to me in my clinical practice with anterior segment invasion. For example, this case where he had older patient, bilateral anterior segment involvement. After systemic chemotherapy, one eye has already gone for phthisis, and then he was referred, from another center after completion of systemic chemotherapy for the probability of salvage of the right eye. And in fact, with the current modality of intravitreal chemotherapy, intracameral chemotherapy, and also addition of plaque brachytherapy, I was able to save this eye, luckily. Enucleation retinoblastoma, most of the group E eyes lands with enucleation. It could be primary or secondary. But what is very important is when you have to put a foot down, not trying to go ahead with other modalities and considering enucleation as a primary modality when there is clinical high-risk features for systemic metastasis, and as in this eye with subtle proptosis, there is total cataract, there is a preseptal cellulitis, redness, absolute indication for primary enucleation. In fact, this patient had a posterior laminar extension of tumor where she had to undergo chemotherapy. There are situations we start the children in such cases with neoadjuvant chemotherapy in presence of inflammation or vital cellulitis. This also gives us time as far as the parents are concerned to convince them for enucleation, because most of the time in our part of the world, once you tell enucleation, the patient gets lost to follow, but you have to make sure that you complete 6 cycles of chemotherapy, even if you enucleate in between the chemotherapeutic cycles. So we have found, in the previous literature that the survival of post-enucleation was as low as 5% and 20 to 60% die after enucleation. And what was the reason for that? Was not being able to identify the histopathological high-risk features, which means that with these histopathological high-risk features like massive choroidal invasion, retrolamellar optic nerve extension, optic nerve transection positivity, scleral innervation, extraocular extension, there is a high risk of these patients dying of systemic metastasis. So what do we do in these cases? We evaluate them after confirming the histopathological evaluation with an expert ocular oncopathologist. We do CSF cytology and bone marrow biopsy to identify any hematogenous or central nervous system metastasis, and these patients receive adjuvant chemotherapy 6 cycles. Now, cosmetic for a good quality of life, which we also should be taking care. Orbital and extraocular retinoblastoma is a very, very important topic. Now, we do have patients presenting with orbital retinoblastoma. This patient actually was diagnosed as orbital cellulitis, treated with IV antibiotics, not responding, imaging done, and found to have an orbital retinoblastoma. So the global burden of orbital retinoblastoma is very high in low-income countries, Africa, which is, as per this, retinoblastoma, more than 50% of presentation of RB in Africa. Well, this is the protocol that we follow for orbital retinoblastoma in India, thanks to Dr. Hunawa, who had put forward this protocol. It's called the Intensive Multimodal Treatment Protocol. I was fortunate to be part of this project, where we start with high-dose chemotherapy. After every 3 cycles, when I say high dose, it's an escalated dose of the BEC protocol. was a patient with orbital extension, bone marrow metastasis, where she survived. And I recently saw her under 5-year follow-up, and she's doing extremely well. So I would like to highlight the fact even orbital retinoblastoma without CNS metastasis has a good prognosis. When it comes to CNS metastasis, we have still not found a solution. Most of these children, including trilateral retinoblastoma, the survival has been extremely dismal. When it comes to regional lymph node metastasis, bone marrow metastasis, as I told you, with high-dose chemotherapy and bone marrow transplant, most of these cases, there is a possibility of life salvage, but with central nervous system, it's very, very difficult despite intrathecal and craniospinal radiation. So the take-home message would be retinoblastoma is a curable eye cancer. It's always good to detect it early because the life salvage is more than 98%. Now, applying the right treatment protocol and the right treatment modalities in these advanced diseases is so very important as far as life salvage and eye salvage is concerned. Thank you so much. Our effort has always been to save life, eye, and vision. Thank you for having me here. Thank you so much.
Thank you, Fairooz, very much for your participation and the very interesting and comprehensive lectures. You see, we are in Africa as well, seeing advanced cases, and it's important to identify the high-risk characteristic and maybe following your protocol. Recently, I have seen a patient with bilateral advanced D disease and pinealoblastoma as an initial presentation. And this was a happening that never happened for the last, I don't know, 15 years or so. I have never encountered an initial presentation with bilateral advanced and pinealoblastoma. What is your experience? And the leptomeningeal disease is a very grave disease that we really don't have an answer for it. So what would you advise, and what was the experience about similar cases as well?
Hi, Dr. Ihab. Am I audible?
Yeah, you're coming up nice. Yes, go ahead.
Okay, right, yeah. So as you rightly said...
Yeah, we hear you.
You can hear me, right? Yeah. As you rightly said, once it is a central nervous system metastasis, especially I had actually put in that slide, I don't know whether there was an interruption in the voiceover for those slides, whether it is meningeal extension, optic nerve extension beyond the apex, and mass, an intracranial extension of a mass or a pinealoblastoma. Most of the cases has been very, very dismal. I should say 100%, but still we go ahead treating these patients with, the CHG protocols, and we give intrathecal chemotherapy, but always it has been only to extend few months of survival. We have never had any child, who survived a CNS metastasis in our series. Literally none. I would say zero.
Okay, so more and more efforts are needed to be done for, as you mentioned, earlier diagnosis and very prompt management as well. Thank you very much, and we hope to have you next time in real life, in person as well. We'll see you in Goa by the end of the year. Yeah, thank you. Bye-bye.
Thank you so much, Dr. Ihab. Thanks a lot. Yeah.